Hello, Dr. Katwa. Thank you so much for being here to share some of your pearls of wisdom on sleep disorder breathing in young children, the signs and the symptoms. This is your area of expertise, and we're very lucky to have you here. Thank you.
Thank you, Sharon. Thank you for having me.
It's a pleasure. Let's start with this question. What are the key signs and symptoms of children's sleep breathing challenges that you see in your clinic?
So, I'm a pediatric pulmonologist and a pediatric sleep specialist. I work at Boston Children's Hospital. I work at a tertiary hospital, so my population is slightly biased because I see a lot of sick kids, kids referred with some sort of much later in the game because they must have missed through the process, and also for a second opinion from different colleagues. So, with that said, I also precept for young fellows and trainees. So, in those clinics, I do get an opportunity to see some of the kids from an earlier part of the spectrum. If you talk about sleep disorder breathing or sleep breathing, these are two entities. So normally during sleep, breathing should be quiet, mouth should be closed, and regular, and at a particular rate depending on the age. The younger the child, particularly infants, breathe at a slightly faster rate because they cannot take a deeper breath. The volume of the air which goes in is not much, so they need to breathe slightly faster. So as the child gets 2 years and older, the respiration is below 20. So now what happens is if there is a disordered breathing during sleep, so any deviation from this norm is called disordered breathing. Any disordered breathing is not sleep apnea. So sleep apnea is a type of disordered breathing, which is probably much later in the course of the spectrum. So if you talk about disordered breathing, a mouth breathing is a disordered breathing. Rapid breathing during sleep, if you're breathing at a rate of 30 per minute for a child who's more than 2-year-old, is disordered breathing. If your accessory muscles are working, that means you have retractions. You're working hard to breathe is called disordered breathing. If you're snoring, is disordered breathing. So, and if you're stopping to breathe, and then you're choking, gasping arousals, is disordered breathing. So these are the common symptoms which typically present. But if you really focus into the disordered breathing, which is in the context of sleep apnea, the most common symptoms are mouth breathing, snoring, pauses, choking, gasping, arousals, and sometimes they can also be having some chronic cough, like suddenly they choke and cough and then they go back to sleep again. So these are the symptoms during sleep with breathing.
So is it the parents that are noticing these symptoms and then taking their child initially to the general practitioner? How does that happen?
Yeah. Initially, when I started my fellowship, I used to not get parents complain that much of snoring, but I think with the public education and articles and just people being aware of snoring is not healthy in children, I see a lot of parents make a small video of the recordings and initially they go to the pediatricians or sometimes they go and see ENT because they have read that tonsils are the most common cause of snoring. So either the pediatricians or the ENTs are the first line of defense. They go to them and tell that my child is snoring. And that is one of the main reasons many people come to the medical attention.
That's such great news that parents are now more aware of audible breathing, because snoring is typically thought as that vibrational sound, but it's really any audible breathing in a way, isn't it? And so if they're picking that up and being able to show it to the doctor, it's easier for a general practitioner or another specialist to raise the issue and ask for more specialist investigation. Yeah.
Yeah.
So what I'm hearing you saying is that there might be two broad groups of children with this sleep breathing challenges, and the sleep breathing challenges go across a continuum, but we could talk about them as children with more complex medical disorders or otherwise healthy children. For those with complex medical disorders, what are those key signs and symptoms that you're seeing? And then what are the treatment modalities that you would be recommending for them?
So if I talk about other than a typically growing child who is healthy with some allergies or asthma, which I consider still under the typically growing children. The most common children I see who have complex medical conditions, the number one is Down syndrome. The number two, other genetic conditions such as Prader-Willi syndromes, children with neuromuscular disorders with hypertonia, children with craniofacial disorders, children who are born premature, like an extreme prematurity, who are born around 25, 26 week of gestation, and then they survive a long course in the ICU, and then they are like followed up with multiple other issues such as lung problems, or they have other feeding issues. So these are a set of patients. The other set of complex issues are children with some in addition to the craniofacial, some of the neurological issues such as brain dysfunctions, like they can have Chiari malformations. They can have sometimes I also see children with tumor, sometimes children with a stroke or hypoxic damage during birth, perinatal hypoxia. Those children are also there with cerebral palsy, children with Rett syndrome, children with other complex neurological issues. I can see, because we are one of the tertiary hospitals, we see a host of children which have been described in the textbook, which we may not even see. We may see once or twice in our lifetime as a career. So such a rare conditions we discover. So the children with complex medical conditions have a two-way of evaluation. For example, children with Down syndrome, children with Prader-Willi syndromes, it has been very well published that these children are at a high risk of sleep apnea. So what happens is, once you get a diagnosis of these conditions, those providers who are primarily treating these conditions with Down syndromes or Prader-Willi geneticist, they proactively refer for evaluation of sleep apnea, even though they don't have symptoms. So what the American Academy of Pediatrics recommends is every child with Down syndrome, whether they have symptoms or not, they should get a sleep study within 4 years of their life, or earlier if they have symptoms. Meaning, that means you are proactively looking for the symptoms to the disease to even exist even before the symptoms become apparent. So that is one way of going there. That is for these big syndromes. But otherwise, what happens is these children may have a presentation which is very typical, like snoring. They can have pauses, choking, or very difficulty breathing, or they're working very hard to breathe. On the other side, they can also have they can have recurrent respiratory infections because they're not able to take big breath, or they're also having chronic cough. They can have restless sleep. They can also have difficulty falling asleep and also staying asleep. If you're unable to breathe well, you're not able to sleep well. So these patients can also present with insomnia-like symptoms. For example, certain patients who have underlying seizure disorders. If you have disordered breathing during sleep and you're not getting good quality sleep and good oxygenation, they're at high risk of developing seizures. So seizures can become out of control, or they can have more seizures during sleep at night. So these are symptoms. Any patient who has the underlying condition which gets worse. For example, if they have asthma, if the asthma is getting out of control and you are giving a lot of medications, but they still have out of control asthma, we always have to evaluate for sleep apnea, because if you have sleep apnea, the management of asthma becomes difficult. Similarly, like in adults, you know that if you have hypertension and it is a resistant hypertension, and you're trying to give just medications without looking for the sleep apnea, and you treat sleep apnea, it becomes difficult to control hypertension and diabetes. Similarly, in children who have asthma, if they are not controlled their underlying sleep apnea, they can also have frequent asthma exacerbations. So these can be not a typical presentation like apnea, choking, gasping, arousal, and snoring. There can be an exacerbation of their underlying medical condition, which makes them think about, am I missing something here? And one of the things which people typically miss is underlying sleep apnea.
Yeah. There's such a range of underlying medical conditions that can be associated with these sleep breathing conditions. What about other metabolic conditions like obesity, for example? Are you seeing these kind of kids in your clinic?
Yeah, I think obesity is the number one cause of sleep apnea after adenotonsillectomy. But adenotonsillectomy I see more common in younger children. As the child becomes a little bit older and teenage, obesity is the number one cause of sleep apnea. And close to 17 to 25% of the US population, depending on which state you live, is obese. And about half of the children are either overweight. So you have a combination of obesity kids seeing in all walks of life. And that is one of the most common causes, because once you have obesity, the fat deposition, in addition to the omental tissue and in the abdomen, there is also fat deposition in the neck and in the tongue. So those patients' tongue becomes much more heavier, bulkier, and the tongue is less muscular and more adipose tissue or the fat tissue deposits. And when you sleep, the tongue tends to fall back because of the gravity. So they tend to have more degree of sleep apnea. There are studies showing that about 40 to 50% of the obese patients have sleep apnea. And I'm seeing morbidly obese. These teenagers who are between 14 to 18 years old, who have a BMI of more than 50, they are coming for bariatric surgery at a pediatric age group. So they are getting all these surgeries in the 16, 17 years old, and they have a significant sleep apnea symptoms. Not all obese patients have sleep apnea, but a significant portion of them. And these days, bariatric surgeons are referring them for sleep evaluations before they put these children for bariatric surgery. Whether they have symptoms or no symptoms, they do sleep studies for these patients.
Yeah, look, it raises the issue around, treatment modalities as well, doesn't it? What would be the role of the medical systems or the health systems like the hospitals in educating around diet? Because things like obesity, which are common in Western countries, actually, not just the US, but in Australia too. It's becoming a very big problem, but it's also seen as a preventable problem. So are you seeing any moves towards preventive healthcare in the hospital system?
I think the preventive healthcare in the hospital is there, but in a system like US, where like particularly where I practice, is a tertiary hospital. So we are so inundated with all of referrals with a complex system. The healthcare system has to be, compartmentalized. You cannot expect a hospital like us, even though they talk about it, I go and talk about it. But my time is more on management of the patients who have been already so sick and almost falling through the cracks that I need to take care of it. But I think the preventative healthcare should start right from parents, from home to school, the teachers, not only pediatricians, but also other practitioners who are like dentists, for example, have a big role in the preventative care. If the patient is seeing a lactation consultant, it is the right time to educate the mother about the baby's diet, weaning. Everybody should play a role in preventative healthcare, and also obviously parents reading and public health campaign by the government is an important thing. So when they come to the hospital, it's more become like a sick care. Even though we do talk about preventing further down once you already hit a point so that they don't become much more sick again. But by that time, the focus is more on managing the disorders, managing the obesity. In spite of what we do, it's more focus on the management because that's the need of the hour at that time.
So it'd be great if there were partnerships, wouldn't it, be between the hospital care and all the medical, dental and allied professionals who are sitting outside the hospital system that can, as you say, when they are treating and seeing young families in their care, whatever their profession is, they do have an opportunity to provide critical information about health and lifestyle. Because some of these diseases are preventable, of course, not all. So when you talk about populations like Down syndrome, Prader-Willi, Rett's, actually, when you were talking, I was thinking about Beckwith-Wiedemann syndrome as well. And there's so many different types, isn't there? But that's a different kind of health management than what could be otherwise healthy children. You said that you're not often seeing those otherwise healthy children. What would be the percentage in your care that are?
So I do see a lot of healthy other typical children, and sometimes they come to me directly because parents are aware or the insurance allows to see me. A lot of families, the insurance don't allow to see me directly because I'm a specialist. They have to go through a pediatrician, and that depends on the pediatrician's knowledge about who they refer. So I think about, depending on, if I have a different clinics, I have segregated my practice into specialty clinics where I work with the ENT. We also had an orthodontist who recently, had to take a medical leave, but we used to have 3 people seeing these patients together who are referred only by a specialist. They have persistent sleep apnea, they have Down syndromes, they had adenoid tonsillectomy, they're not tolerating CPAP. So they are definitely the ones who really have a problems which have gone through the initial treatment phase. So at that time, we consider doing drug-induced sleep endoscopy, some other surgical interventions, or we try to do some orthodontic interventions along with myofunction therapy. So that is a clinic where I see those. And also, we also consider some of the Down syndrome for the hypoglossal nerve, which is a newer treatment in that clinic. On the other clinic, we do see patients who are coming from the community. They're referred to see my trainee, my nurse practitioners whom I supervise. So these are the patients who are typically healthy or obese, or a child with allergies, asthma, has big tonsils, and mom brought a video to the pediatricians and they come and see me. So in my practice, depending on the time I spend, about 50% of my practice is occupied by the complex patients. About 30 to 40% are by the typically from the community, but very simple medical problems, not complex. But I got 20 to 30% are coming for second, third opinion from different institute with the same condition.
It really takes a forensic approach to unravel all of those pieces that contribute to sleep breathing with many children. So what options for testing are there? Polysomnography. Do you want to talk about polysomnography?
Yeah. So polysomnography, as you know, is the gold standard for treatment for evaluation of sleep apnea. So it is an extensive study. It shows a lot of data, but it also needs a certain level of skills and experience to look through in between the lines. But if you look at the standard polysomnogram, it is very good in picking up somebody who has a bad sleep apnea or a severe sleep apnea. So it really picks up. But the limitation of the polysomnogram is when somebody has so-called primary snoring or upper airway resistance syndrome or a very mild degree of sleep, scorable apneas, what I call it as, you may not be able to really characterize the degree of the obstructive burden, what I call as. The patient is symptomatic, clearly symptomatic. But when it comes to characterization of that breathing on the sleep study, sometimes there is a limitation. So, but remember, we are dealing with more complex patients, more obese patients, where the pre-test probability of having sleep apnea is much higher. So we have a much higher percentage of sleep studies being positive, just the type of population we see. So we do use the American Academy of Sleep Medicine guidelines to characterize mild, moderate, severe. But on the patients who are on the milder spectrum, some centers do use esophageal manometry to measure their effort and also characterize the degree of obstruction. But in our institute, just because of the complexity and other medical, legal, and financial reasons, because it definitely increases the cost of the study significantly, and some of the clinicians don't cover it, and it ends up being on the parents. So we don't use that. But I do spend a lot of times on looking at the waveforms, even though there are no apneas there. We do characterize under the category of mild sleep disorder breathing, which can still throw some lights onto the degree of the obstructive burden. It may not be as classic as some of the Downs patients have sleep apnea, but we do characterize. And we do use sleep study as the evaluation, test of choice for us to evaluate sleep apnea in the center. And we have a 13-bed state-of-art brand new sleep lab opened recently.
Yes, tell us more about that.
Yeah, so we had like 7-bed lab for the last 8 to I think almost 15 years for that matter. And initially we had only 2 beds, and over a period of time we have slowly increased because of the volume. We are one of the first pediatric sleep lab in the US, maybe in the world at that time when the research was being done, and it has ramped up. We just built a brand new 13-bed lab, which is individualized room with attached bathroom and toilet. It's very nice and very child friendly. So we can study children right from infants, they're discharged from 2 weeks of age, all the way up to like even adults into their 35s who have complex medical conditions. It also has negative suction room. So in future, there's a pandemic, so we can still continue doing sleep studies without even actually stopping it. So they can negative suction room. In addition to that, these are equipped with suction, oxygen. We can do CPAP titration, ventilation. We can also high flow. We can also do other interventions like hypoglossal nerve titrations in those studies. And we can also do some research trial for drugs. They can draw some blood in the middle of the night if there is any study of the drug being studied. So it does include a host of different type of sleep studies, like tracheostomy. Sometimes you do cap the tracheostomy to see if the patient is ready for decannulation. So all those kind of studies can be done, and it's one of the sought out pediatric sleep lab in the entire northeast of US and in the nation.
It sounds like it's really well set up for doing research as well.
Yeah, yeah.
Yeah. And the parents can stay in there with the children, is that right?
Yes, we have a couch where they can pull from a chair, it converts into a bed. So every child less than 18, a caregiver or a parent has to come. We don't just study kids on their own and the parents cannot drop it and leave. So somebody has to stay with the child. If they're more than 18, they can stay alone. So there is a couch for the parent, and they can bring their own teddies or blankets or pillows. They like to sleep with that. They bring their medications. We don't have TVs in the room because we took away the TVs. We didn't want kids to come and watch TV and not fall asleep. But we have some iPads, and after that there's a curfew time, and after a certain time we stop using that so that the kid can fall asleep. They also are very light tight, means the light does not come. It's very dark, so that they can facilitate sleep. They also have sound barrier. For example, if the next room there is an infant and starts crying in the middle of the night, it does not disturb the other patient. So and we also have rooms for the families. For example, a mom has two kids and there is a single mom and she brings the other child. So in that situation, in a social situation, there is a room in the side of the sleep lab. The mom can go and sleep with the child there, so that, or the father is snoring, himself has sleep apnea, who comes with the child, and he can use the CPAP and go and sleep there. So we have family rooms, we have kitchenette, we have a bathrooms. Each sleep lab has a bathroom in that, so they can take shower in the morning and they clean themselves. So all those facilities, thinking, there is a kitchenette, there is food. So thinking from a family, how comfortable we can make it, like an iPhone charger, like, things like that, people can forget it. So thinking about each need of a family when they are, it's not like a hotel, they feel like they're at home, and we want to make it as homely as possible.
It sounds fantastic. I mean, it sounds like a model that would be fantastic to be copied all over the world. One of the biggest challenges with children is having access to that kind of sleep testing if it's needed. And another question, well, first of all, actually, people like yourself are a little bit rare. It's not always easy to find a really experienced pediatric sleep specialist. There's that, and also the facilities, and kids being able to access them. Traditionally, polysomnography would be a one-night study. Are you able in these facilities to do more than one night at all?
So we do one night, and we also have a protocol. We can do a prolonged night. That means typically the child comes at 7 o'clock. The study starts by 9 o'clock by the time you hook up, and it ends at 6 o'clock in the morning. But the technicians who does the night study has a 12-hour shift. They come evening 7 o'clock and they leave in the morning 7 o'clock. In some patients who have excessive daytime sleepiness or teenagers, we do a prolonged study. That means the second technician comes at 7 o'clock in the mornings and takes over, and those studies run till noon. They have some other disorders in addition to the sleep apnea things. This 2-day sleep study back to back. One, it is not covered in the United States for medical, for the financial reasons, and the reimbursement will not happen. For that reason, we don't do it. But if we get good sleep, the whole point is to mimic, because there are data showing that your night is not as typical in the sleep lab because you are in a new environment, the bed is uncomfortable, people are watching you, you're hooked up, there is so much of noise going on, sound barriers, light barriers. For that reason, the quality of the sleep and the REM sleep is not as robust as one would see at home. And people have questioned the results of the sleep lab. Oh, a lot of parents say that, oh, that is not a typical night. My kid doesn't do that. But he came and he did not sleep. I don't believe the result. I don't think it's accurate. So we go this situation back and forth, and taking those feedbacks, we have designed the program so that it can facilitate at least those kind of situations, to give them as sleep close to as normal as possible. But if we can get one night good sleep, if we get like multiple REM cycles, I think there is no difference between 1 night or 2 nights, even though there can be a seasonal variation, because kids in particular season have more symptoms, like in allergy seasons, and other seasons they don't have. So we encourage parents to consider doing sleep studies during the season of exacerbations rather than just doing it when they are totally fine.
There's so many things to think about, isn't there? And I have a couple of questions going on as you're talking in my mind, and one of them is actually around placement of the electrodes and getting kids to be comfortable with that, because that's sort of an abnormal thing, isn't it? So the technologists who are placing the electrodes need to be very skilled. How do they do that? How do they get kids to be comfortable with that in the sleep lab?
Oh, that is an excellent question. I think that is one of the biggest part of the training I have done. A lot of technology. If you really look at the way the technologies are trained right now, I'm putting a lot of efforts in actually training the sleep technologists how to be child friendly, and we have a program for that. If you see the sleep world in America, most of the technologies are initially they start as adult technologists. So they either come to children's hospital, either a change in job or an opportunity, or somebody really likes it, but they just come for various reasons, including financial or close to their home or whatever is possible. So once they come, if you have a typically growing child, it's not a big deal. But remember, we have kids with autism, with ADHD, kids with sensory issue, kids who don't allow to touch you, kids who have so many craniofacial abnormalities, you don't know where to put the leads and things like that. So what happens is all these technologists have to do 3 months of observations along with the senior technologists to learn that thing. Number one. Number two, we also have a child life specialist. These are the specialists who are basically trained how to handle developmentally or differently able children and how to talk to them, how to work with them, how to make it less stressful. That is an art, and we go through a rigorous training for that. Number three, we have thought about how to communicate and take the help of the parent to help with them. A lot of times, children's don't want a stranger to come and check. So the way they dress also tries to be very child friendly. And in some situations where the parents tell us or tell me that, Dr. Katwa, I don't think this kid can tolerate, we need to do something different. I try to bring those children's few days before to the sleep lab for a sleep lab desensitization, meaning they come in the afternoon, they walk in the sleep lab, we allow the child to sleep in the bed just to get familiar with the room and play around. And we also have some leads which we are disposable. We try to put it there when the child is awake, and sometimes we send the leads with the child, with the parent, to their home so they can try those leads and try a CPAP for that matter. So the kid is not completely new to an environment. They come on a day and everybody starts hooking up 20 things on their face and on the chest. So we try to do these things, and in extreme difficult situations, we know that the difficult child is coming. We tell the child life specialist to work a evening shift, so that person is there. So as soon as the child is come, rather than the child waiting in the child waiting area with other 10 kids and getting anxious, we directly room into a separate room so they are contained. And there is a special senior most technicians, and we have a child life specialist to help assist with that. So there's a lot of planning and coordination goes in developmentally challenged kids to get the data. But if we can plan, we do get a pretty good data once we make it more comfortable and child friendly.
Yeah, it just takes incredible skill.
It's a lot of words, yes.
It's a lot of work, and it's not just with the kids, but it's also with the parents. Sometimes parents get really anxious as well. So we're not just dealing with the children, but it's working out how to talk to the mum and the dad, or either or, in a way that helps settle their anxiety. Because if they're feeling a bit anxious, then the children bounce off that too. So the technologists really have to have great people skills, don't they?
Absolutely. I think we have created videos and we mail them, and also we have on the website. At least they know what all the people don't know. Sleep study, they don't know what it is, right? So visual, I can tell them like, okay, it involves leads and belts and cannulas and things like that, but they really don't get a picture, visual image, a lot of people, unless they have gone through that once. So one, the video tells them what it involves. At least they have that. I think the best thing what we have seen, and we have also got a lot of feedback from the families, and we get some amazing comments like, this is great. And sometimes we get comments which is not great. So we take those comments and we try to use those as a feedback to the group of technologists to see how it make it, one, you have to make parents more comfortable before you make the child comfortable. You cannot try to just focus on the child and neglecting the parent, because if you just focus on the child, they say, you know what, I know my child better. And I think parent-led directions for the child application of the leads is the best way, rather than you trying to do, even though you may be the senior most technician and you know everything. But if you don't involve the parent and take their lead, I think there can be a disconnect at their expectations, and sometimes it can cause more friction.
Oh, I couldn't agree more. As you're talking, I'm thinking this would just be a fantastic kids book, you know. And I'm also
We
thinking,
haven't actually. We have made a book. One of our technicians wrote a book with a cartoon with an elephant coming for a sleep study, and all those things. So we have those books. Sometimes we give them in the clinic so that they can read those books. Ellie the elephant
yeah,
having a sleep study or something like that. So
yeah,
and there's also a lot of similar materials in the Amazon. We recommend people to buy
yeah,
and help them.
yeah.
The kids.
Fantastic. Oh, I'd love to see that. But anyway, and as you're talking, I'm thinking about the many clinics and the many kids that I've seen over the years. And one of the things that I have to do is get them to open their mouth so I can have a look. And sometimes kids just don't want to do that. And so we turn it around and we say, well, I don't think your mummy can do that. Can you see if your mummy can do that? And so we swap it around and get the kids to get their parents to do it. Even 3-year-olds can do that, actually.
Yeah.
So
Yeah.
that's a tactic that I've used in the clinic over the years, just to help kids, just give them a little bit more time, to get used to the idea that they're going to do something that's a bit different, or for some reason they're feeling anxious about it.
I think the clinical care is an art, as you said, Sharon. You don't need to hit the room right away and start examining the patient. You need to make your space, yourself comfortable. There is a much more body language to that. So parents need to be comfortable with you. The child needs to be comfortable with you. A lot of times, the moment you enter, the child just goes to the mom's lap and clinges. And that's the reason. Typically, I don't wear white coat in my clinic for the pediatrics for that reason, because it can be white coat anxiety in pediatrics. So we try to avoid that. And we try to be as casual, like one of the visitor in their house, as much as possible. You're not making a point that you're a doctor. You're trying to make a point that you're one of the family member or a friend of mother, and just being that friendly with the mother. If the communication with the mom and you goes well, the child sees that energy, and then they are more cooperative with you. If there is a little bit of friction in communication, that can translate of the child being a little bit uncooperative. But said that, there are some kids who really are very anxious or very sensitive, and I don't try to torture them. I know what it is. The symptoms are consistent. Let's go ahead with the testing. And once they come for the second time for the follow-up, they're much more receptive for you to touch them or do that. So rather than putting a spatula in the mouth and trying to put the tongue down and try to just to get a glimpse of the tonsils, there is another way of examining them. Their posture, they're just looking at their face, open mouth posture, the facial profile. There is much more science we can do without even actually touching the patient, which I think a lot of people don't pay attention to that. So I think the examination starts from the moment the kid starts walking into the clinic or you walk into the room.
And sometimes it just takes time. It really just takes time and massaging that relationship. And I love that point that you made about white coat, especially with the children with complex medical disorders. Many of them have been through so many tests and so many clinics with so many doctors, and they genuinely don't know what's coming next, really, do they? So for them, it is, a real fear. So yeah, that's
Not
really,
only that, the parents are themselves seeing. So imagine, I think as much as the child himself is going through trouble, but imagine a life of a mother who has a child who is developmentally challenged or a complex medical condition. They are constantly, their life revolves around that child. And I always make it a point to appreciate the mother, like how difficult it is, and what you're doing is an amazing job, and it's a very difficult job in the world. Driving these kids to multiple appointments in an urban area, navigating the complex healthcare system, navigating through the insurance denials and approvals, making sure these treatments are given, getting to the surgeries, getting to interventions, and communicating complex medical data from different and processing it. It's not an easy way. Even the physicians sometimes have trouble understanding things, and I can only imagine the parents. So I have a lot of respect for mother parents of complex medical conditions and challenged kids.
Yeah, it's so true. And they're juggling so many things and so many specialists, so many different doctors. You know, there could be ENT, respiratory, neurology, just to name a few. There could be dental, orthodontic, and then there might be an allied health. Well, there probably is an allied health practitioner or two or three, because we've got physical therapists and occupational therapists and speech language therapists and myofunctional therapists. And there's just so many people
And
on
not everybody's on the same page. Many people are of different opinion, and digesting that and trying to build people on the same page. It's a very full-time job and a very mentally stressful situation.
It's so true. And social media doesn't help sometimes because of the parents are often looking to social media and looking to other mums actually for information because there's so much information there. They're really not sure what to believe.
Yeah, I think so. I think social media has a double-edged sword. I think you can use it for your advantage. I think the parents group of, say, like a Down syndrome parents group, Prader-Willi, these are amazing resources, and there are family-driven networks of the disorders.
Very true.
And that is an amazing resources for them to do. But I always tell my my families that I think, in fact, I encourage them to be on those groups so that if people are doing something different, they can bring, and I'm open to try something which I've not tried based on somebody else's experience. It's a collective learning. But I always tell that before you make changes, drastic changes based on, here, say the situation in that patient may be different than your child, even though they have the same conditions. So try to discuss with the healthcare professional to make sure that, this is consistent, something safe for your child to be done. So as I said, parents come with request, I want this hypoglossal nerve for my child, stimulation device for my child, where the child is not a right fit because the other kid had a different situation, even though they have Down syndrome, but it is not a right fit for your child. And then that sometimes takes an effort to sit with them, explain them. But if you really put that time and eye contact and really explain them, I think I never had any situation that parents are not convinced. I think even though the parents are educationally and they are not highly educated from a science perspective, but they understand the problems of this child and the treatment you're trying to do. So if you give them a good reason and explain them why it is a good or not a good treatment, I don't think so anybody has any issues. Even in the language, people, I use interpreter. It works beautifully.
Yeah, it's so interesting, isn't it? How how to give parents agency so that they feel like they also have some control around decision making and what kind of treatments they truly want to understand it. And you mentioned hypoglossal nerve stimulation, which is relatively new medical treatment option. My understanding is it would be very helpful for kids with true hypotonia. Is that?
Yeah, eventually, I think it will come there. Right now, it is not an FDA approved for that indication. The whole point in Down syndrome is not that the syndrome is responsive. Hypotonia is a part of Down syndrome, and Down syndrome have a lot of sleep apnea. And what you're trying to treat is actually the low tone of the tongue. But there are other hypotonic conditions. I think may not be as severe, but something in the middle. This device may really work well. So somebody, you don't want to give CPAP for the rest of their life. They don't have any surgical options left, but they just are hypotonic. So that may be a good device for those patients. I think there are some studies being planned, and we will be getting some data soon.
Yeah, and it's good to have the options there, particularly for the Down syndrome group. What are your thoughts on use of CPAP for kids as a treatment modality?
When I see pediatric OSA, I'm talking about run-of-the-mill kids, okay, not healthy kids now. CPAP is a treatment, not a cure. So the day you don't use CPAP, your sleep apnea is back. So for treatment of sleep apnea in children, I'm always aiming for cure. I may not achieve in all the patients, but my aim is to cure that they are done. So the secret for curing sleep apnea is pick up early or prevent it. Early treatment or early intervention is the only way. If you delay the treatment of sleep apnea because it was not severe enough to meet the criteria, and you treat when the kid is around 7, 8 years old, the treatment outcomes are not the best. Meaning there will be some residual sleep apnea persisting, or the sleep apnea may come back as an early young adult or a teenager. if there is underlying condition happening. So I typically go with the surgical options or myofunctional therapy or craniofacial modification interventions. If there is residual sleep apnea, it has to have a symptomatic burden. That means they have significant symptoms. Number two, they have a significant disease burden on the CPAP, on the sleep study, because the insurance don't cover the CPAP unless you have a documented OSA severity on the sleep study, because otherwise you have to pay out of pocket. So we do use CPAP, and most of the patients who end up on CPAP for me are either obese patients, or they tend to have some degree of underlying low tone or Down syndrome or some of the genetic syndromes. Very rarely, sometimes somebody doesn't treat the nasal obstructions pretty well. They have treated tonsils and adenoids, but the obstruction still lies here. Those patients also have the sleep apnea, and I've seen them ending up on CPAP. But I try to go back and try to talk to the ENT to see that either we can address it either by surgical intervention or an aggressive allergy treatment, or maybe an expansion to improve the nasal airways. So that has really helped to remove the CPAP. So I don't see CPAP as a long-term solution for healthy kids. If the patient is requiring, I think I'm missing something in the diagnosis. I do use for short-term for a year or two while they lose weight or they get the underlying condition treated. But if somebody is requiring CPAP for a long-term, these are the patients, invariably they have significant obesity or the large tongue or low tone. I really don't worry about that. But if I tend using CPAP for a long term, I worry about secondary effect of CPAP, which I see a lot in my follow-up because I have some complex patients. They tend to develop more mid-facial deformity. For example, I have quite a few patients who have Down syndrome. And as you know, Down syndrome have mid-facial maxillary deficiency. So when you put a mask, particularly the nasal mask in the middle face, and you try it tightly and you're using it entire for the child span, including from young age all to 7-8 years, they clearly develop significant protrusion of the maxilla. They can also develop the class 3 and also can underbite. So we have patients like that, and I have 2 to 3 patients who underwent, MMA, like maxillary advancement surgery much later in the life as a side effect of chronic CPAP therapy. So CPAP is good as a short-term therapy for me. When somebody requires CPAP for a long-term for any reason, they should be very closely monitored for craniofacial deformities and also use devices and masks which are having less pressure on the mid-face.
Yeah, it's really, so you're saying that CPAP is, you try for that not to be a long-term solution if absolutely possible. And in virtually all cases of obstructive sleep apnea, there will be an anatomical component of some kind, perhaps related to jaw growth. So at what point are you, children in your care, accessing dental or orthodontic interventions to facilitate better growth of the upper jaw? Knowing that also that with CPAP that exacerbates mid-face deficiencies and upper jaw issues.
I don't consider treatment of sleep apnea either or. A lot of times my patients have complex, multiple issues going on. They have a high arch palate, they may have a small jaw, they may have a low muscle tone, and they may have adenoids and tonsils. So when I see 3 different causes of obstruction, I try to quarterback. I try to see what is the lowest hanging fruit which can make an immediate impact. For example, growth modifications requires time, right? If you put a palatal expansion and you try to modify the airway, these are over a period of months to years. And if the kid experiences obstructive breathing and fragmented sleep and intermittent hypoxia for 2 to 3 years while you fix that, that can have some impact on the brain permanently. You really don't want to do that. So you want to give a head start to the child. If the tonsils are the low-hanging fruit, I go for tonsil surgery. I try to go for tonsils, reduce the severity much lower. Even though the sleep apnea is cured and I see a craniofacial deformity, even though the sleep apnea is gone and the AHI is 0, I still send those patients to the orthodontist and our dentist to start working on that, because I have seen that children which are a short-term cure with underlying craniofacial deformity and you don't correct that, in few years or as a teenager, as a young adult, the sleep apnea will come back. Yeah. So you need to have an eye not only for the short-term cure, but also prevent the long-term recurrence of sleep apnea. So I always, not necessarily all the patients, but if I see an opportunity for me to refer to the dentist or orthodontist, I always refer them. If I have an
what age are you recommending those intervention?
I don't go by AHI. I go by deformity. For craniofacial deformity, I go by deformity. As I told you, right? For example, I see a patient with high arch palate and a tonsils. I do tonsil surgery, and the sleep apnea goes away. For example, it becomes zero. If there is a craniofacial deformity, I still refer them.
Mm.
I don't wait until they come back again with problem because I know they will come back to me. So
Yes.
I'm proactively now I'm taking a preventative measure in them at that point.
Yeah. And how old are the kids when you would start thinking about dental orthodontic intervention?
I think I always look in that one, but again, I'm not a dentist. I'm not expert in that one. And again, there is a breadth of a sleep dentist who really understand the pediatric. There are a lot of people who understand the older kids and teenagers, but when it comes to less than 6 years, I don't find any people who do expansions or therapy. But sometimes I just do the myofunctional therapy. Hopefully, it can help. But they consider expansions when they are about 6 years above. Many people refuse to do expansion at that time. And again, I don't tell orthodontists what to do. A lot of times I refer to the family orthodontist. If they are uncomfortable with managing that, then I refer to a couple of my colleagues who are into sleep medicine and they can help with that. So for me, I don't see an age for that one, but I think if there is a better protocol developed by the dental world, there may be devices which are like, removable devices they can use for slow expansion rather than a rapid maxillary expansion for younger kids. And also along with myofunctional therapy, you may autocorrect them if you start early so that you may not need a MARPI or a frank expansion later on. But if you don't do that because we cannot do it, then you need to do something like this.
So, do you have allied health professionals skilled in myofunctional therapy in your hospital system?
Right now, we have a lot of SLPs, but they are not practicing myofunctional therapy. Just because, again, I told you the focus is more on the feeding, swallowing, dysphagia, that directions. So, but I have a lot of colleagues around who are into myofunctional therapy, and now with the televisits and things like that, and people have access to that. So, I do refer them to get that intervention.
Yeah, you've given us so much fantastic information, like this insight into what you are doing in your clinic and the kind of care and the attention to detail with all of these kids. They're incredibly lucky to be in your care, might I say. Yeah, it's such a great pleasure to hear from you today. I rather than taking up too much more of your time, I just have one last question. Is that okay?
Yeah, absolutely.
Yeah. I'm going to talk about health clinics outside of the hospital. And do you think that every child in every health clinic should be screened for breathing health and for sleep health?
I think so. Again, what's happening is the pediatricians are given so many screening tools. They need to screen for speech, they need to screen for swallowing, they need to screen for acne. They have been given so many, and sleep apnea is just catching up the popularity, and now they are coming on board for them to screen. So there is a host of pediatricians who are practicing right now who themselves did not have training about sleep apnea. And even today, I can tell you in Harvard Medical School, most of the medical students may have 1 or 2 lectures on sleep apnea, or maybe for that matter, sleep. They learn sleep from a physiological perspective, not from a practice perspective. Even the pediatric residents who are graduating and going into practice, they don't even have sleep as an elective because if you go and practice as a pediatrician, I think personally, 20 to 30% of their practice is related to some form of sleep problems from the pediatrician. It's so common because we do see all the time. And unfortunately, I think they are ill prepared. They read something, they do some CNEs, they get some experience, but they are not able to consider. They will wait until the parents bring to you as a problem. I think the best thing in that situation is one, I have a course dedicated only to the pediatricians about medical people, how to learn and screen for sleep disorders. I run through Harvard and we did it during COVID, we had to give a break and we're going to restart that again. This is just dedicated to the practicing pediatrician and maybe some dentists who can come. What are the common sleep disorders, how to screen them, and how you can manage what you can manage and how to then refer to the specialist. That is it. Not to make them an expert because they already have so much on their plate with vaccinations and well child visits so that we don't want to make things complicated. So that's my goal. I think they're not only screening for the questionnaires, They should also screen for breathing. How is your child breathing? Is it audible during sleep? Is your child mouth breathing? Is your child working hard to breathe? There's your child, and then trying to connect. If you have asthma and you're not able to control asthma, you should always go back and see, am I missing sleep apnea? If your child comes to the clinic and the blood pressure is high, for a child who's otherwise healthy, screen for sleep apnea. So one is proactively screening at a well child visit, and also in certain conditions we are difficult to manage, go back and screen sleep again, sleep duration, sleep symptoms. So I think that has to become pediatrician, dentist, and for that matter, even for any parent, and when I talk to a lot of parents blog, I say your job is to, a lot of people say, I don't watch my kids sleeping. I think at some point you need to go and sneak and listen. I mean, it's not invasion of privacy, it's just as a health, screening. And sometimes they travel and stay in the hotel in the same room. There may be another opportunity to pay attention about their child's breathing.
You're making so many great points. I mean, like in the perfect world, every pediatrician, wouldn't it be great if they did have sleep on their radar? I mean, just sleep is a critical pillar of health. That's even before we start talking about breathing during sleep, which is really one disorder of multiple disorders or things that can go wrong in sleep. But if every pediatrician had it on their radar, even things like mouth breathing, which is actually not picked up yet by a lot. But I have to say, there is a groundswell, like a type of movement that's happening with a lot of the allied health professionals and the dental professionals who see children, particularly in the preschool years, and there's a great movement towards early identification of some of these key red flags, could we call them, or these key signs and symptoms that it doesn't have to be complex and it doesn't have to take a lot of time, but to recognize those little red flags so that they might be the person that can start or initiate the care for these children, get them to the right specialists like yourself if they need them.
Absolutely. Yeah. I think another way is, if you really look at the school, right? School is a great opportunity. If you take the school who are at the lower percentile of their scores, math scores, schools, and they're not doing well in school. And there was a study, they took all the kids who was at the bottom of the percentiles and they screened them for snoring. That's it. Not a sleep study. That's the questionnaire. And then they compared that with the children who were at the top of the percentile. A significant portion of the children who are in the lower percentile had a history of snoring. So by treating snoring, you can even improve their grades. So poor school performance themselves, they don't need to, because they don't come to the pediatrician with the poor grades. That is much later in the down the line they come to the pediatrician. They don't go, if you don't get good grades for the first few exams, you'll not go to the pediatricians. School is a great thing. Making parent aware that poor school performance is a sign of sleep disorder breathing or sleep disturbance for any reason should trigger them to evaluate, number one. Number two, if you have been diagnosed with ADHD, this is such a common symptoms, you cannot start treatment for ADHD until you rule out sleep apnea and sleep disorder breathing symptoms. Right? These are just two things I'm talking about. Behavioral issues. Kids who are very having meltdowns, or they are very cranky in the afternoons and they just don't behave themselves. So all these symptoms can be a subtle symptoms of sleep disorder breathing, because it is very to focus symptoms only during nighttime. You're snoring, you're not snoring, but there are a lot of daytime symptoms which are markers of sleep apnea. I think we should focus on those, starting from school, making school nurse aware, making school teacher aware of sleep apnea. I do sometimes give lecture to the high school students, but by the time it's too late, they are in the high school. The highest impact you can have is in the preschool, elementary school children's, because these are the children in the early phase of brain development. If you can pick up and treat them, I think you can make a huge impact in their development.
So true. The nighttime clues, how they wake, are they refreshed in the morning, and what happens during the day. So many pearls of wisdom. I can't thank you enough for coming on today, but I don't want to take any more of your time. I'm just going to pause the recording here for a moment.